Hello class, it's time to start on chapter 29, which is disorders of ventilation and gas exchange, or as I like to say, the work of breathing. And we don't really usually think of breathing as work, do we? But just to quickly review the physiology of breathing, I want you to remember that an inhalation is an active force, meaning you require contraction of skeletal muscle in order to cause volume changes, in order to cause pressure changes in your alveoli, what we call your alveolar pressure. And then air will move from your external environment, a high pressure, down into the alveoli where there's a low pressure. Exhalation is just a passive process. We simply relax the primary muscle of respiration, which is the diaphragm, and when it relaxes, of course, it moves back up to a more superior position and applies pressure on the lungs, and this means alveolar pressure, the pressure inside the lungs, is higher than atmospheric pressure, the air pressure around you, and the air flows from outside of your lungs to the external environment. Throughout this lecture, I'm going to be talking about different types of respiratory diseases, and they primarily fall into one of two classifications, either obstructive or restrictive. Obstructive diseases relates to blockage of airways. They are primarily a problem with getting air out. Exhalation or gas exchange, that's their problem. I always remember the obstructives are problems with X's, exhalation and exchange. Restrictive diseases is a problem with expansion issues, meaning that the lungs are not as compliant as they should be. They have too much elastic recoil. And I will be be reminding you of different ways that we can cause changes in volume in our lungs. So why is it important to discuss lung issues and ventilation and gas exchange disorders? Well, if you have ventilation or gas exchange disorders, you're not going to get enough oxygen into your blood. So the term for that is hypoxemia, which means a reduction of blood O2, normally given as a partial pressure of oxygen in blood. Most of you probably learned that you can relate partial pressure of oxygen to the concentration of oxygen dissolved in the blood. And those two are not the same things. However, you can say there's a correlation. For example, if you double the partial pressure of oxygen in blood, then you have doubled its concentration. But the absolute values, when we speak of partial pressure of oxygen, it's in millimeters of mercury worth of pressure, and that's not the same as saying concentration, which would be something like millimoles per liter or something like that. So how can you get hypoxemia? That means reduced oxygen in your blood. Well, you can have inadequate oxygenation of the lungs, meaning you don't have enough oxygen getting down into your alveoli. That could be because you're at a higher altitude. At a higher altitude, there's less oxygen, total molecules, and there's, of course, less pressure because of that. You could have a decreased muscle activity, say a neuromuscular disorder, or maybe myasthenia gravis, where you have flaccid paralysis of your breathing muscles because your nicotinic acetylcholine receptors are being destroyed. This could also be a problem with hypoxemia. It could be because of a pulmonary disease with gas exchange or causing gas exchange. Maybe you have hypoventilation, you have impaired diffusion, you have inadequate circulation through the pulmonary circuit, or ventilation perfusion mismatching. And ventilation perfusion mismatching is certainly something you should have learned in physiology. And just to maybe stoke the fire a little bit for that neuron, I'll remind you that that discussion deals with dependent and non-dependent regions of the lungs, and both oxygen, or air I should say, and blood have densities. And so the lower regions of the lungs get more air and blood, but more blood because gravity pulls on it. It has better density. And the upper regions get less air and blood, but they get more air than blood. Anyway, your lungs use a variety of chemical signals to try as best they can to match the amount of ventilation to perfusion. Along that discussion, you should have learned about physiologic shunts and physiologic dead space. We also can get hypoxemia if there's inadequate transport. Maybe the person's anemic, or the hemoglobin is made aberrantly and can't transport oxygen, or there's low blood flow. The hypoxemia, which means low oxygen content in the blood, as I just said, can lead to hypoxia, which means low oxygen content in the tissues. Can there be hypoxia without hypoxemia? Sure. Blood can be well oxygenated, but the tissues might not be able to use the oxygen correctly, say if they've been exposed to cyanide poisoning. That effectively stops the electron transport chain. Alright, so let's begin our disorders of ventilation and gas exchange with just an overview of disorders of the pleura. Alright, so what is pleuritis or pleurisy? Well, those two are basically referring to inflammation of the pleural membranes. But it's the inflammation of the pleural membranes that can lead to pleural effusion, which is fluid accumulating in the pleural space. Now, we've heard this type of situation before. We know that around the surface of the lungs we have visceral pleura, then a potential space, and then lining the inside of the chest wall is parietal pleura. And this is a similar setup that we saw with pericardial membranes, right? So these serosal membranes can become inflamed and release cytokines and chemical signals and inflammation signals like histamine. And yet again, we're going to see the same thing over again, changes in permeability, capillary permeability, the KF. We're going to see changes in capillary hydrostatic pressure because of arterial dilation. So again, all of this is going to lead to pleural effusion. So I just want to remind you from our previous conversation that pericarditis had sort of a dull pain, right, that slowly came on and it reflected into various parts of the upper shoulder and the back, and it was rather persistent. It didn't necessarily go along with ventilation changes like inhalation and exhalation, but certainly if someone coughed or breathed deeply, they would complain of pain. Pleurisy pain is much different. It's much sharper. It comes on very acutely. People that have pleurisy pain can tell you where they were the first time they felt it. It comes on so rapidly and so sharp that people can remember where they were the time they received the pleurisy pain. Do you remember what the pleural membrane is? I mean, I just reviewed that. It's a double membrane. It's a serous membrane that surrounds lung tissue. We have parietal pleural membrane, and then on the surface of the lung you have viscera pleura. And so in between the two you have the pleural cavity, or sometimes it's called the interpleural space. So if we're talking about pleurisy, we're talking about the accumulation of fluid. And typically there's only about 20 milliliters of fluid in each of the pleural cavities, and you have two. There's only a thin layer of fluid. But in the case of pleurisy, now where would the fluid come from? Where would there be additional fluid? Why would there be additional fluid? Like I said, two primary reasons. We're going to talk about inflammation, histamine release. This is going to lead to vasodilation, that's one, and that's going to lead to changes in capillary hydrostatic pressure. And we also know that there's going to be a change in KF, the capillary permeability. And this means that we're going to have proteins leaking out of the blood compartment and going into the pleural cavity. It's important to note that with these pleural membranes, there are capillaries nourishing them. You have capillaries around them nourishing them, and when you have inflammation, you're going to get the protein leaking due to changes in KF, like I said, in vasodilation. Same changes as what we saw in pericarditis. So the increased vasodilation leads to increased hydrostatic pressure, and the changes in KF leads to increased capillary permeability, and then the protein leaks out into the pleural cavity. Your pleural fluid, colloid osmotic pressure goes up, and it's going to draw fluid from both sides, both serosal membranes, into that space. And that's where you accumulate the fluid. That can occur slowly over a period during any inflammatory response. And that's your IgE response, remember? We talked about your IgE response and the mast cells and the basophils. That's the same response that we saw before with pericarditis. Or, you know what, another way you can get pleurisy is through trauma. You see this in patients sometimes in automobile accidents when the steering wheel hits them in the chest region, and it doesn't initially show. They seem to be fine, and then a few hours later they get that sharp pain because that can fill very quickly because of trauma. What you're doing, instead of leaking the blood vessels, you're actually bursting them, and so they're filling the pleural space rather quickly. So why is there pain? You have pain receptors called nociceptors in and around the lung. What are your nociceptors doing there, you might be asking? Why would you want nociceptors in the lung area? It is to prevent overinflation, that's why. As you exercise, for example, running back and forth, you begin to inhale and exhale rapidly and very deeply. Ever notice you get chest pains? And that is your nociceptors being stimulated by the overinflation. And those same nociceptors get activated by the increase in the fluid volume as well in pleurisy and pleural effusion. So the pain in pleurisy is different than pericarditis due to the pleurisy pain being caused by pressure, and they feel it during breathing, whereas pericarditis is a friction rub. One of the diagnostic tools for the effusion, and remember the effusion is the filling. Instead of saying you're filling that space, it's just effusion. There are 5 isozymes for lactate dehydrogenase, or LDH. LDH1 is from heart muscle and red blood cells. LDH2 is from white blood cells. LDH4 is highest in the kidney and placenta and the pancreas, and LDH5 is highest in the liver and skeletal muscle. LDH3, that's the one in the lungs. So this is the guy you're looking at right there. And how do you set these up? What's the technique to monitor LDH3? Gel electrophoresis, of course, just like what we used in our serum protein electrophoresis. So if you saw an accumulation of LDH3, then that's your diagnostic tool. But that takes a while. So in the meantime, you can do an X-ray, and you can pick up on this pleural effusion right away. And I've showed you an X-ray up here on the screen. You would use the LDH as kind of a confirmatory test, but on the X-ray you can see the pleurisy. With the X-ray you see a clear space, and then you see kind of a halo around the lung. And the halo is actually the fluid, and you can see a lot of fluid accumulating on this patient's right lung. So ordinarily you would not see this kind of halo effect, so they're either a saint or they've got pleurisy. Alright, so before I go on to other disorders of breathing, I want to take a moment to review some important concepts that you probably did learn in physiology, but I know that for some of you it was quite some time ago. We need to talk about compliance and recoil. The lungs are not muscular structures. They cannot change their volume on their own. And in order to get air to move in and out of our lungs, we have to have volume changes. We're not vacuums. We don't suck air into our lungs. We don't do it like a straw. Rather, we cause thoracic volume changes, and those volume changes in turn cause pressure changes in our lungs. So in order for our lungs to move with the chest wall, they need to be compliant, they need to be stretchable, they need to be distensible. But then we also need the lungs to have recoil ability. So all this comes down to compliance and elasticity. Compliance can be best demonstrated here in the top graph picture. Compliance equals any change in volume for the same change in pressure. So look at the x-axis, I have distending pressure, and the y-axis I have volume. If we were to pick any value on the x-axis for distending pressure, and then draw a vertical line straight upward, we would intersect line B first, and then at a higher value we would intersect line A. And that means for the same pressure, A is more compliant or distensible than B. Say these were two different lungs. So the lungs can be stretched or expanded during inspiration. Compliance is reduced by factors that produce resistance to distension. I'm going to talk about those. Elasticity. What do you think of when you think of elastic fibers? Most students think of stretching, but stretching is only half of the property for elasticity. It's also recoil ability. If you stop and think about you wearing your favorite pair of underwear every day of the week, with washing of course, and then all of a sudden you get them out of the dryer and you put them on over your hips and they stretch out like the size of a moo-moo on you, and then all of a sudden you let go of the elastic waistband and they fall down off your hips. Well, you probably pick them back up and you say something like, "Oh, the elasticity has gone out." So they still stretch. They stretched out with no problem, but it was the recoil that was the issue. And recoil ability is probably the most important quality of elastic tissue. The snapping back into original shape after stretching or inflating. That's what the lungs need to do. So lungs are going to go in the direction of their natural recoil during expiration. When you exhale, the lungs get to recoil. But when you inhale, the lungs have to be compliant. And it's the chest wall that likes to recoil outward. And when it goes outward during an inhalation, your lungs have to be compliant and stretch and go along. So if I rearrange the equation for compliance, and I have this down here at the bottom of the screen, compliance, as we learned on the previous slide, means for any volume change, any volume change is predicated upon a pressure change. So another way of saying that is for any amount of pressure change, how much will the lungs, their volume, change? So I'm going to rearrange the bottom equation and solve for volume. How can we get volume changes? We can change compliance, or we can change the pressure difference. Now PALV stands for alveolar pressure. That means the pressure inside the lungs. And PIP stands for intrapleural pressure. That means the pressure in the pleural cavity. The difference between alveolar pressure and intrapleural pressure is the transpulmonary pressure. Transpulmonary pressure reflects inflating pressure, meaning that's the pressure required to get the lungs to be distensible, to open up. All right, so let's start with compliance. Let's pick the compliance side shown here in pink. Lung compliance is a measure, of course, as I just said, of the ease with which the lungs can be stretched. Now, what can increase lung compliance? How readily they open up? Surface tension. The fluid inside the alveoli is a watery fluid, and water has great cohesive ability, right? Water has amazing surface tension. If you think about trying to spread a drop of water out evenly on top of your kitchen counter, you recognize that water wants to ball up right away. So we have to break that surface tension. Well, surfactant is a detergent-like molecule that I'm going to tell you about in just a little bit that helps to disrupt the surface tension. The elastic tissue inside lungs is obviously very important for compliance. If we want something to stretch, we want elastic tissues. Again, two properties for elasticity: stretchability and recoil ability. If a person has less elastic tissue, then their lungs are not going to be as compliant. And if this happens, they're going to have a hard time with inhalation. So we can see this with pulmonary fibrosis. When a person's elastic tissue is being replaced with scar tissue or collagen, that's not very stretchable tissue. Now let's switch over to changes in transpulmonary pressure, which is the difference between alveolar pressure and intrapleural pressure. Now, the lungs want to recoil inward, and the chest wall wants to recoil outward. This means that the pressure inside the intrapleural cavity is actually negative, creating a negative pressure of the intrapleural cavity where the pleural fluid is. So it's like a vacuum in that space right there. It actually has about, I think, -3 millimeters of mercury worth of pressure. So how can we increase the pull, the fight between these two structures, the chest wall and the lungs? Well, we can have more elastic recoil of the lungs. We can have more elastic recoil of the chest wall. Or we can give more contractile activity to the breathing muscles by sending more action potentials through the motor neurons to the diaphragm and intercostals. So all of that is a way where we can get a greater transpulmonary pressure to get better changes in lung volume. And again, we need changes in lung volume to precede airflow. So let's begin the talk on the work of breathing. There are two major difficulties in breathing. We need to overcome the resistance of the air passageways. And we really need to come back to Ohm's law, which basically says that flow equals change in pressure over resistance. But we can rearrange that to solve for pressure. Pressure, change in pressure, will equal airflow times resistance. So in order to get changes in pressure, to get airflow, we're going to have to overcome the resistance of airways, and I'm going to talk about that. We also need to overcome the elasticity of the lung. That means its natural tendency to want to recoil inward. So we want to make the lungs more compliant for inflation. So again, the normal elastic recoil for the lungs is inward, and the chest wall wants to recoil outward. If we dissociate the two, if we actually introduce an air bubble in the pleural cavity and disrupt that suction, that -3 millimeters of mercury, we'd actually see the lungs go inward in atelectasis, or a collapsed lung, and the chest would literally pop outward. I'd like to begin with our discussion of overcoming the airway resistance with a discussion on Poissonier's law. Poissonier's law basically states the factors that are involved with resistance. Now we can apply this to blood like we did in last chapter, or we can apply it to this chapter with respect of radius. Obviously we're talking about the breathing airways, the air passageways I should say, not breathing airways. So if we stop and think about a primary bronchus branching off of the trachea, leading to a secondary bronchus, to tertiary bronchi, to smaller bronchioles, to terminal bronchioles, to respiratory bronchioles, to an alveolar duct and an alveolar sac, we are getting progressively smaller structures but more numerous. So I want you to remember that Poissonier's law states that resistance and radius are inversely related. If radius goes up, resistance goes down. If radius goes down, resistance goes up. And this relationship is not a linear relationship, it's to the power of 4. So we need to think about that and apply that to Ohm's law. So let's first start with obstructive diseases. I want to remind you that with obstructive diseases, we're talking about a problem with getting air out of the lungs mostly. Why do I have up here difficulty moving air in and out of the lungs? Well, one of the obstructive diseases I'm going to tell you about is asthma. And any of you out there who have asthma are going to say to me, Kara, I have problems with breathing both in and out. Yes, I understand that, but it's mostly noticeable during an expiration. So obstructive disorders is an issue with exhalation, like I said. And here's the reason why. If you look at this picture on the bottom right, and what you're basically seeing with those purple air passageways with the A pointing downward is that when you are actively exhaling, meaning really using your abdominal muscles to help push air out, excuse me, there's an elevated intrathoracic pressure. And the more that you try and exhale, the more your intrathoracic pressure builds. And this is going to push on the smaller air passageways. And these smaller air passageways don't have cartilaginous plates. So in the effort of trying to exhale out air, you are in fact shutting or collapsing those smaller air passageways, and you're trapping dirty air. So that's going to be an area, of course, of high resistance, which means if you have high resistance, you're not going to get good flow. That meaning you're not going to get a lot of air out. And I will talk about having an elevated functional residual capacity, or FRC, in obstructive lung diseases when I give you more concrete examples as I go through emphysema, chronic bronchitis, and asthma. So first I'd like to review the general problems with obstructive respiratory diseases. What can be the problem in obstructive pulmonary diseases that can limit exhalation or gas exchange? Well, basically, like I said, with obstructive disorders, we're talking about a problem with an obstruction. How can this obstruction occur? It can be from increased resistance to airflow inside the lumen. It can be from outside the air passageway, or it could be because of the actual air passageway itself, not the lumen, but the actual tube. So I'm going to go through all of this. If we're talking about the inside of the lumen, it could be that we have resistance to airflow because of excessive secretions like mucus in the case of asthma and bronchitis. Or maybe we have fluid leaking from pulmonary capillary beds because of an asthma attack leading to excessive IgEs and therefore histamine release. Or maybe someone has an obstruction in the lumen because they've inadvertently aspirated something. My brother used to shove raisins in his nose, and it used to be real trendy in the 80s to have sticker books, and I remember he would pick off some of our tiny little puffy stickers and put those in his nose too. So, you know, a little kid shoving stuff in his nose and then aspirating those or inhaling those, and they get past the epiglottis into the air passageways, that can certainly be an obstruction. What about the air passageway itself? Not the lumen, but the actual tube-like structure. Well, it has layers or tunics, and there's smooth muscle that lines these air passageways, and that can contract. And that's a type of obstruction, right? Reduced radius leads to increased resistance. We also can have hypertrophy of the bronchial wall, where the bronchial wall, when it's being hypertrophied, actually goes into the lumen. We've seen that kind of hypertrophy in the heart, right? So the heart has abnormal remodeling when there's too much hypertension or blood pressure. Well, the lung can also have remodeling, if you will, of air passageways where the tissue grows into the lumen. We also can have damage occurring outside of the air passageway, meaning outside the smooth muscle layer, just on the external surface of the bronchial, if you will. We can have destruction of the lung parenchymal or parenchymal cells. And what are parenchymal cells? The parenchymal cells are the main cells of the lung that are actually contributing to the alveolar walls, the actual tissue that's generating the air passageways. And if we're talking about destruction of the lung parenchyma, then we're talking about destruction of alveoli, loss of alveoli or alveoli collapsing to turn into larger alveoli. And that means we're losing surface area. And loss of surface area means loss of opportunity for gas exchange, which means obstructive issues. So when we're thinking of resistance or obstruction, I want you to think about Poissonier's law, where resistance and radius are inversely related, as shown here on the screen, and radius is to the power of 4. On the right of the screen, you're seeing a set of lungs, and you're seeing airflow from the atmosphere into and out of your lungs. So from the atmosphere to the lungs to the alveoli, and from the alveoli out to the atmosphere. In order to get air to flow into the lungs, we need the alveolar pressure to be below atmospheric pressure, because air will only flow from an area of high pressure to low. So let's play. If an airway narrows to half its original radius, then what will happen to resistance? According to Poissonier's law, it goes up. But how much? 1/2 times 1/2 times 1/2 times 1/2 is 1/16. So 1/16 substituted for r to the 4 here. Flip that around to calculate resistance, and that means resistance has increased 16-fold. Now, if you want to maintain the same airflow, but your resistance has increased 16-fold, then what are you going to have to do to your pressure gradient to maintain the same airflow? Well, if your normal change in pressure is 2 torr, also known as millimeters of mercury, as shown in this picture, 760 versus 758, and your resistance increases 16-fold, well, then that means you're going to have to create a pressure gradient of 32 millimeters of mercury. And that means you're going to have to expand the chest wall even further to get that 32 millimeters of mercury worth of pressure change just to keep the same airflow. So how are you going to do this? Well, we're going to see how the alveolar pressures are controlled by changing the volume of the lung. Alright, so I want to talk about changes in resistance so that the lung can change volume, so that it can change pressure. And this discussion has everything to do with attractive forces, which is actually discussed in chapter 29. The mechanisms involved in the pathogenesis of chronic obstructive pulmonary disorder really usually are multiple and include inflammation of some type and fibrosis of the bronchial wall, hypertrophy of the submucosal glands, and hypersecretion of mucus, loss of elastic lung fibers, and alveolar tissue. This is what I just highlighted on the previous 2 slides, how we can have excessive secretions in the lumen, hypertrophy of the bronchial wall, and loss of alveoli. I mean, I just mentioned that to you. Inflammation and fibrosis of the bronchial wall, along with excess mucus secretion, can obstruct airflow and cause mismatching of ventilation and perfusion, and this can lead to hypoxemia, which is what I referred to at the beginning of this lecture. Destruction of alveolar tissue decreases the surface area for gas exchange, and loss of elastic fibers impairs the expiratory flow rate. This increases air trapping or dirty air, an increase in functional residual capacity, as it's well known as, and predisposes the airway to collapse. The term chronic obstructive pulmonary disorders usually applies to three categories: asthma, emphysema, and chronic bronchitis. The textbook, however, only lists chronic bronchitis and emphysema, but I've always learned it as the triad, the big three, so that's what I'm going to teach to you. So I want you to remember that with all three of these issues, COPD is a problem with getting air out. And this picture here shows the mechanisms of airflow obstruction in COPD. The top shows your normal bronchial airway, and it shows that elastic fibers that are anchored into the bronchioles, when they're pulled on, they can also pull open the bronchioles, and so they're providing tractive forces, as we say. So as the elastic fibers stretch and are pulled taut, they also open bronchial walls. Excuse me, my allergies are still not going away, and I apologize. In part A, you're seeing hypertrophy of the bronchial wall, and you're seeing this hypertrophy going inward and decreasing the lumen. And this is what I referred to in the past or previous two slides. In B, you're seeing inflammation and hypersecretion of mucus, as what can happen with asthma, of course. And in letter C, you're seeing loss of elastic fibers that can hold the airway open. So in all three bottom cases, we're seeing that the lumen is becoming obstructed in some way, either because of hypertrophy, secretions, or loss of tractive forces. All of that is going to lead to increased resistance, and that means we're going to have a problem with getting air out. So, with increased resistance, as I said before, we're going to have to use an increase in volume changes to get changes in pressure in order to get airflow to come in and out of the lungs. So if you look at the blue line shown here, that's a normal amount of pressure change required in the alveolus in order to get air to come in, as shown in inspiration, or out, as shown in expiration. So down the bottom, you're seeing breath volume. During inspiration, we inhale about 500 milliliters, and during exhalation, we exhale the same 500 milliliters. If, however, there is too much smooth muscle constriction, if there is too much mucus production, or if there is any bronchial hypertrophy, in order to get the same 500 milliliters in and out of our lungs, if we have increased resistance, we're going to have to increase the amount of pressure changes inside the lungs many, many times fold, just for the same amount of airflow. So, how can we help someone with obstructive pulmonary disease? Let's just pick a person with asthma. They have too much smooth muscle constriction, and we want that muscle then, of course, to relax. So we can give sympathomimetics, we can give beta-2 receptor drugs that target beta-2 receptor, like albuterol or epinephrine, but we also can block the receptors in the lungs used by the parasympathetic division. We can give muscarinic acetylcholine receptor blockers. All right, time to go on to our second installment where I actually talk about all three parts of chronic obstructive pulmonary disorder.